translate into an A1C of
6, 8.
10. Wait, no, it's like 7, right?
8 to 10. Yeah, about 8 to 9 probably. 10 would be about 240. Okay. So, and normal is what? What's our, we haven't talked about goal yet, but our goal is less than 7%. Okay? So, that's what we would do. We wouldn't treat much until people started, we didn't have meters, we didn't have any way to check their blood sugar. Their A1C didn't come about until 1978. So all we had to go by was them peeing in a cup and testing their blood sugar to see if glucose was present. If glucose was present, then we would start to worry about it. Okay? We only had one drug, a PO drug, and those were the sulfonylureas, and we had insulin. That was it. Metformin came about in about, when does metformin? I can't remember when metformin came out. The glutazones came in about mid-90s, so probably about mid-80s we started to have 2 drugs available, and then we got to 3 drugs in 95. So there really wasn't much to treat them with. So at this point, these people got all kinds of complications. When I was at your stage, I saw lots of 20-year-olds that were already blind, already going through amputations, already on dialysis. Because after 10 to 15 years, usually, and in the most severe, that's when the complications set up in about 15 years. So I saw quite a few when I was a young resident. So the debate went back and forth. So finally they designed the Cadillac of Studies, and that is this DCCT. So what they did is they said their premise was good control as that can be accomplished by intensive use of insulin will lower the rate of complications or will slow its progression. That was their premise. They came out with, they did only type 1s, and they divided them into 2 groups. And those 2 groups, one is that they went to conventional treatment. At that time, and at the time when I started the family medicine, conventional treatment of diabetes ended up with an average A1C of about 10%. When I started family medicine, we had 663 diabetics in that population. Our average A1C was 11.8%. Okay? So they divided them into conventional treatment, and then they put them into intensive treatment. They were highly criticized because it was a very expensive program. They said it's a Cadillac, nobody will ever be able to do it. So in the very intensive treatment, they put them on 4 times a day insulin. They had a dietitian, they had a team of 5 people assigned to every patient. So they had an endocrinologist, they had a nurse educator, they had a dietitian, they had an exercise physiologist, and a behavioral psychologist. Okay? So a team of 5. And they worked with those people for 6+ years. And in the end, they found that their primary endpoint was retinopathy. The relative risk reduction in retinopathy was 75%. Yeah, 76%. That was huge. So it showed that if you could intensively lower blood sugar, that you could delay the onset of complications. You all live with it, so it's like, man, no big deal. But then it was a big deal, because it showed for once and for all, it changed practice. If you can look at any study that changed practice in diabetes, that was it, is the DCCT. The difference in the 2 groups was only 2 percentage points. So the intensive group, their average A1C was about 7%. The group that was just conventional, their average was 9%. They tried to go to 6%. That was their original goal, but the amount of severe hypoglycemia that they had was too high, so they eventually had to back off. So this is where your goal comes from. This is why we say less than 7% is what we shoot for. But look at this. 2%. How much does that correlate, what does that change into an average blood sugar? 70 points. It's the difference between having a fasting of 190 and a fasting of 120. That is not much. That's why I'm telling you, baby steps make a difference. Small changes and improvements in diabetes control pay off. Small changes in weight make you more insulin sensitive. Being more active makes you more insulin sensitive, and it translates into better blood sugar control, less complications. This was a fairly young group. Complications way down. And those that, in each of these groups, they had people who already had complications and those that didn't. Those that had complications had a slowing of the progression. Now, the other thing is they continue to follow these people. There's another study called EDIC. You can tell I love this, it's just so exciting. It is, it's huge. The EDIC, I've got EDIC, but it's EDIC. The EDIC study. So they kept following these people. And what they found that over time was that the people in conventional, they gave them the option to move into the intensive study arm afterwards, and these folks continued on. What they found over time, just like anything, you lose weight and then you creep back up, right? So in the people in the intensive, their A1Cs kind of went like this, and the people in the others went like this, and so they pretty much paralleled each other after a while. But what they found in those two groups, that even though this group's A1C trended up, there was a legacy effect. Because they have had a period of really good blood glucose control, they still, even years out, have lower incidence of retinopathy, nephropathy, and neuropathy. That's huge. It's big. Okay. So that's where your number comes from. That's where the evidence is. And it changed therapy. People were like, oh, we'll never be able to do that. We'll never be able to replicate that. But you guess what? It made a huge change in therapy. It made a huge change in the way people treated and moved towards, nobody anymore would ever be happy with 9% or 10%. Okay? All right, so that's the DCCT. Now, haven't you, when you look at studies and you look at the population that they are studying, have you been told, oh, you could expand that to anybody? So it's applicable to anything. Is that true? No. What have they told you? If a study is looking at a certain population, can I then take and extrapolate that to another population? Okay, but they did here. They did extrapolate this from type 1s to all diabetes. And they did it because they said the core is hyperglycemia, because once you've got that, all those complications then come into play. So this is one of the few times that I've seen where they have done that. But they made this across the board, all diabetics, type 1, type 2, even though this study just did type 1s. Another thing that helped them in doing that was another big study called the UKPDS, which came out, it started in 1978, and they published their study findings in about 93, about the time that this one. So that study went for eons, and they added in every arm imaginable. What they started with is they said, okay, good glucose control makes a difference, and it doesn't matter what you use to accomplish that, it's getting the blood sugar down. So they had a big metformin arm, and that's why metformin has become the drug of choice, because in that group, in that study, UKPDS, the 38, UKPDS 38, that arm of the study, that one showed that people who were on metformin that were overweight, placed on metformin, did better and had better cardiovascular outcomes. So that's where metformin got its plus. Okay. So that's why we do what we do. So goal of therapy, we talked about, we've already talked about A1C. This gives you a very detailed explanation. If you go down to the bottom of that page, goals of therapy. So the goal is less than 7%. This is a population goal. What do I mean by that? It's not the same for everyone, but for a group of type 2 diabetes, it's the goal. Okay? So some people will be able to get down into the 6 to 6.5% range. Okay? So we've come a long way since that. We used to say everybody needs to be below 7%. Now the approach is individualized. It's America. Have it your way. It's McDonald's approach, or whichever one it was. Burger King, have it your way. Okay. So now our approach is, we would like to get it down to 7% because we know that that's where we really we decrease the development of complications. But some people can't get down there, and it costs a lot of, it can take a lot of drugs to get down there. At the risk, the lower you go with A1C, the higher the risk of hypoglycemia. Hypoglycemia isn't good because it really affects your neurologic development as a kid and as an adult. So now we individualize. So if somebody can get down to 6 to 6.5% with very little hypoglycemia, good. But some people can't. Some people may be able to stay between 7 and 7.5%. Some people may just, the best or the most lenient we are is under 8%. Because there we're still under microvascular risk. This may be people who don't have very long to live. They've got a diagnosis where their length of life is probably not going to be impacted by the fact that they have diabetes. Okay? It may be somebody who has cognitive defects. And so putting them on something more stringent or using a lot of medications may not be in their best interest. It may be intellectually they can't deal with the demands of the disease, or something physical that's getting in the way. Okay? I think I gave you all, let's see. Less stringent may not be appropriate for those at risk for severe hypoglycemia, have limited life expectancy, have advanced complications, so advanced kidney, cardiovascular, or severe comorbid diseases, or have had diabetes for many years and have trouble attaining 7% despite the use of multiple glucose-lowering medications. Here are some examples of patients that I took care of. I had a young man, or he was probably in his 30s. He had cerebral palsy. He could not talk. He could communicate with me through his tablet. He was a hoot, but he verbally couldn't tell you. His parents, he still lived with his parents, very good relationship, but they would frequently be gone for several weeks at a time, and he had a caregiver who would step in. She was more afraid of lows than anybody in the family, so she would not allow, she just always overfed him, so it was always a struggle. Because he could not tell you so much about lows, what we elected with him is we elected to stay around 7.5%. I had another man who had a traumatic brain injury and had moved back in with his mom. He was like 60, she was like 85. She was an amazing woman. They both were an amazing couple. But he also had a very hard time communicating lows with her. So he was one where we stayed between 7.5% and less than 8%. Okay. So that's where the individualizing comes in. Where's the benefit and where's the risk? The risk of lows is big. Lows can kill you. They don't kill you often, but it is a severe risk. Okay. So letting that float and looking at where it's best for the patient is most important. I can guarantee you I will ask you something about A1Cs and appropriateness for a given patient description. So the recommendation is to monitor that A1C every 3 months. Okay. Especially if you're doing a lot of changing of therapy. If you have somebody who is stable and their response is about the same all the time, then you can go down to 2 times a year. Now, if they're always 10%, that doesn't mean you only do it twice a year. So they're more when that twice a year is for people who are well controlled and stable and are pretty much always in the same goal range. That next slide is the data that came off of partly the DCCT. So for type 1s, keeping blood glucose in target range. For heart disease, 42% reduction. And this is like a 1% drop in A1C reduces microvascular complications on average 30 to 35%. That's huge, 1%. You can get that down in most people. Nerve damage as much as 60%, eye disease as much as 75%. That's huge with nerves because most patients with diabetes get neuropathy. So blood glucose goals. So you all know your A1C goals. We know normal fasting is 70 to 99. We usually don't shoot for that. If you do, and you're having to use insulin, a lot of people will get too low. So you'll see that the preprandial means what? Before meal. So the before meal blood sugar the goal is 80 to 130. You need to know that. So that's what you're going to tell your patients. I want your blood sugar in the morning to be between 80 and 130. Treatment goal for post, because I told you that that postprandial peak has a lot of influence on A1C, right? So the post 1 to 2 hours should be, now here's where you have 2 camps that are very different. The ADA says less than 180, the endocrinologists say less than 140. I say you do the very best you can. 180 keeps them from spilling sugar. Less than 140 gives them much better A1Cs. And we'll see when we get to gestational is we really want to keep under that 140 because it keeps that baby from getting too big. Questions about those? Know those numbers. Those are walking around numbers that you would always tell a patient. So after the diagnosis of prediabetes, what are we going to do? Lifestyle changes. If we need to, we will start them on a medication, those at higher risk. Treating the cardiovascular and monitor for their development of diabetes on an annual basis. Now, if I was not going to see them for that length of time, I would give them some parameters. That's usually what I would do with patients. As long as your blood sugar is staying in this range, I don't need to see you. If something major should happen, you gain a lot of weight, you change jobs and now you're sedentary, or you start to see blood sugars in this range, whatever I name it, 200, staying in the 200s, I want you to call me back. Something along that line, especially if I'm going to go a long time between seeing people. Treatment of type 2. Okay, so that's prediabetes. So let's move on to, now they have type 2. So there's a flow sheet, that colored sheet that you picked up. This one. You might pull it out and just keep it beside as we walk through these different drugs. This comes from a joint consensus conference between the American Diabetes Association and the the European Diabetes Group Coalition. There are very few head-to-head comparisons of different drugs in the treatment of diabetes. There is no start here, go to this, then go to this. It isn't like in blood pressure. So that's what makes it hard, I think, for a lot of people to treat diabetes, is because now there are so many drugs out there. There are so many types of injectables. What do you do? So this is a way to think of it. And I think they laid it out well. This is the way I think about it when I am looking at somebody, when I'm treating someone. You always start with metformin. It's where the most evidence lies in terms of outcomes. Now, what do you add next? Or what do you replace it with if that doesn't work? Well, this is where the knowledge of those drugs and what they do comes into play. If you look at each of them on the side, it talks about efficacy. So one of your objectives says, know the clinical response or expected clinical response of a patient to putting them on a drug. That is huge. You must know those. Otherwise, I don't know how you will guide yourself. Okay? Expected response means what kind of A1C lowering can I get out of that drug if I use it? If a person's blood sugar is 10%, it makes no sense for me to use a drug that lowers their A1C 0.8%. None. Okay? I'm going for power. I'm looking for one that'll do 1 to 2% in combination with another one that'll do 1 or 2%. Okay? So that is what that is important. So efficacy tells you what's the expected lowering, usually of A1C, or expected lowering of fasting blood sugar. Now they're going to start throwing in the next guidelines is cardiovascular risk reduction as well. But we don't have to deal with that in here. The other is to look at their hypoglycemic risk. You got to look at that patient and look at them. If I lower your blood sugar too much, what risk am I putting you on? If you are 80 years old and you live by yourself, I am hardly going to put you at risk for too low of blood sugar. If you're somebody who refuses to monitor their blood sugar and you operate big machinery, I am not going to put you on drugs that lower your blood sugar without your awareness. Okay? So those are the kinds of things you need to think about. How much am I going to lower you, and what risk does that put you in the way you like to live? The other is weight. All the drugs we had in the beginning is if I'm going to sit here and fuss at you, need to lose weight, you need to lose weight, and then I put you on drugs and they all make you gain weight. How would that make you feel? It's terrible. So now we have drugs that we can choose from. We've got drugs now that are weight neutral or will help with weight loss. Write this down or keep it in mind. Any drug that affects the release of insulin is going to cause weight gain. If it doesn't affect insulin, it'll usually be weight neutral or weight loss. Now, why is that?
Insulin.
So what's happening is that when they are, until you put them on something that improves insulin response, they are taking in calories that they never capture. If your blood sugars are running 300, you're peeing out a lot of calories. You never capture it. Never affects your body. Now I put you on insulin. Guess what? You can hold on to all those calories. So what's going to happen to your weight? It's going to go up. So a lot of these, when I put somebody on insulin, I'm looking for, did your weight go up? Because it tells me it's working. Then I work on, let's get your calories down. Okay? So anything you put them on that will affect their insulin release or give them or replace their insulin, their weight will go up. Okay? Side effects. So looking at what are the most likely side effects that are going to occur, and are they going to aggravate anything that the person has? So some of these drugs will make heart failure worse. A lot of these patients, your older patients have had diabetes for a long time, they're already going to have substantial cardiovascular disease, and they'll have heart failure. Some of these drugs will cause new onset heart failure. Some of them will worsen heart failure that already exists. A lot of them have GI side effects. So we're going to look at those as we go through. Then we're going to look at cost. So I don't care sometimes what the guidelines say. If the patient can't afford it, what am I supposed to do? So now the two that are recommended right under metformin are the SGLT2 inhibitors and the GLP-1s. They're very expensive. Metformin is cheap. It's on the $4 list at Walmart. You all come across that? If they're on the $4 list, it means that they can get a 30-day supply. They can get 30 tablets for $4. Okay. So metformin is cheap. Sulfonylureas are cheap. They're dirt cheap. The rest of these are pretty expensive. Then you can go, that's dual therapy, so what do you add next? And then what do you add as a triple? So that's how this one progresses, and then the addition of insulin we'll talk about tomorrow in the type 1, or type 2. All right, so keep that one out, because that I think is, I think they did a pretty good job in the things that you need to kind of keep in mind when you are picking a drug. All right. So let's look at metformin. You always want to start with lifestyle. If their blood sugars are not that elevated, start with diet and exercise first. Especially if they're less than 7, even 8%. Even, I sometimes get patients that are 10+%. But what they eat and their sluggish movements is so ridiculous that if I can get some movement on that, they can start to see what diet and exercise does. If you now there are other people that have very different opinions. If people are symptomatic and they're really high, I will start them on a drug, but tell them that if you will move to this point, we'll consider coming off a drug. But a lot of patients will beg you, don't put me on a drug, don't put me on a drug, don't put me on a drug. It's like, okay, now I've got you exactly where I want you. Here's what you have to do, here's what you need to do, and then you can talk to them about changes that they made in their diet. One of the things you can do as practitioners, and when you do this, is go after the high yield foods. Get the sugar sources. If you're drinking pop, stop drinking the sodas. If you're drinking a lot of milk, stop drinking the milk. If you're eating a package of Fig Newtons every night before you go to bed, stop doing that. So that's what I do, is I go after high yield. High yield, where is your sugar source coming from? If you'll stop that, if you truly don't want to be on drugs, stop that. And look at your blood sugars, and that usually is the better teacher. And then try to get them to move, even if it's small amounts. The other thing with exercise, it adds up. We know that 30 minutes of walking is equivalent to 3 10-minute walks during the day. 10-minute walks, 30 minutes, go off on your 30-minute walk. Same thing, you get the same effect. Okay? So people who don't have a lot of time or they've got a lot of excuses, you can get up and walk for 10 minutes. Okay. So I'm a big believer in, if you can do lifestyles for 3 months. Let them work on that. Usually I don't let people go more than a month, because then it's like, come back, let's see where you are. Let's talk about where you had success, where you didn't. And then if you're making improvements, we'll keep going that way until we reach the point where you can't do it anymore, or you need help. If lifestyle changes fail and the A1C is less than 7%, metformin is the way to go. Look, get your little chart out. Okay, number 1 is cheap, very inexpensive. Efficacy. Metformin is one of the best oral agents. 1 to 2% drop in A1C. That's big. I can tell you that most people, if they're 10 or 12% and you put them on metformin and they will change how they're eating, they can probably come very close to gold. If they're eating like crap, they can get that A1C down, maybe with metformin alone. Okay. So what do you have to think about? So I always tell you all, first of all, think about what drugs you have and then rule them out based on contraindications. So let's go through that. Renal function is the biggest thing you have to think about, kidney, metformin. We used to not give it to anybody who had GFR less than 60, but now we've modified that. So you'll see over there total maximum daily dose. You should know that, 2,500, 2,550, depends on if you use the 500s or the 850s. So that's the total daily dose. You see as you get down to a GFR of 60 or below, you need to start reducing the dose. So down to like you will see a lot of your older patients fall into that GFR 30 to 45. So there is 1,000 milligrams is the max. Look over to the side. Do not initiate therapy at this stage, but if the drug can be continued, if their renal function is stable and they're not having any problems from it. Below 30, don't use it. The reason is that it can cause a very severe effect called lactic acidosis. And its cousin that used to be on the market years back in the 70s called Fenformin. A lot of people died from the lactic acidosis. This drug in no way approximates that. So it's very safe, but in people that have reduced renal function, need to be careful. Other people that would fall into that category would be unstable heart failure. So remember their kidney function is very variable. Liver disease, they can't metabolize the lactic acid. Alcohol abuse. People who drink a lot of alcohol, I do not use this drug with because the risk goes up of lactic acidosis. If they're binge drinkers on the weekend, I don't use it. If they drink a 6-pack at night, I don't use it. I don't know how to tell you where because I've talked to the company and they will not draw a line and say this is too much. But I've got other options, and I always think if I have to stand up and record a line to think what I did, how would I do that? So if they drink a lot of alcohol, I don't use this drug. I move on. And I always imagine that whatever people are telling me, it's a lot more than what they're admitting. Pregnancy, it can be used in pregnancies. It does not have the big power. So it's not teratogenic, it just does not have a lot of power in pregnancy to decrease blood sugars to normal. And in pregnancy, the one thing we're trying to do is keep the size of the baby normal. So it's a very different approach during pregnancy. Okay, so you've got somebody who you can accomplish your glycemic goals, and the goal is what? Less than 7%, and metformin is very able to do that, and they don't have any contraindications. Then how do you start? The other is the recommendations are now coming out is to evaluate cardiovascular benefit from drugs or cardiovascular risk, because because we talked about type 2s being at great risk for cardiovascular disease. Years ago, there was a drug that came out that was on the market for diabetes, and in some large studies they found that its use was associated with greater and higher risk of cardiovascular death, and that was rosiglitazone. After that, the FDA came out and said, okay, anytime a new diabetes drug comes on the market, you must evaluate, after it gets on the market, you must evaluate cardiovascular risk. So now every drug that comes out has to do that. So metformin does improve outcomes. Good glycemic control for long periods of time with this drug decreases cardiovascular mortality. So it is a good one to use in people who have cardiovascular disease or risk. Okay, so you got all that cleared out. Looks like it's a good drug. Can't find any reason not to use it. Then how do you start a prescription? The starting dose is around 1,000 milligrams a day, but here's what I do. This drug, its main side effect is GI. It upsets the stomach, causes lots of bloating, causes diarrhea in some people. So I have found over the years that the best thing to do is start with 500 milligrams. And I have them take it for a week. If they tolerate it and no problem, then I usually write the prescription so that after 1 week, they can increase the dose themselves to 500 twice a day. That's really where I'd like them to be. But I never start more than 500. I'll tell you one reason why. This drug is so valuable. It is foundational. It is a great drug. If you blow it with GI side effects, they'll never go back to it. Okay? So don't start them on 1,500 milligrams a day. Do not start them on 2,000 milligrams a day. You'll lose a portion of those people that won't ever take it again. Start with 500. The gut will build tolerance to the drug. 500 once a day. Have them take it in them. I have them take it with whatever meal they think they can remember it. I would like them to take it first thing in the morning, but sometimes that they're not going to eat. They must take it with food. Okay? At the end of a meal is best. Right after they finish, they've got a full stomach, take the drug. Sometimes if their blood sugar does pretty well during the day, but they're always high first thing in the morning, I'll have them take it at night before with supper or at bedtime if they're usually eating a snack. So remember in the very first module we talked about dose response curves. So metformin's dose response is, like most of them, like this. So this level right here is at about 1750. Okay. You will get the maximum, you'll get 80% of the drug's effect at about 1750. So you've got 500 milligram tablets and you got 850s. I don't use the 850s very often. Mostly use the 500. So my goal is to get to about 1,500 with most patients. If I'm getting good response and they are working on diet and exercise and everything's moving in the right direction, I'll go on up to 2,000. But see, I'm not buying myself a whole lot more, and here's 2,500. So you still have some room to go up. I go up when I know I've got another drug that I need to put on, but the patient is reluctant, or money is a problem. I'll go on up to 2,500. There's no reason not to, but you've got to know you're not going to get a whole lot more. Here's where your big bang is in this range, 1,000 to 1,750. That's your big bang right there. That's where most of the benefit's going to come. You can advance that drug as fast as the patient can tolerate it. Most of the time I go from 500 after a week up to 500 twice a day. And then I'll usually let them sit there for a month. But I'm also pushing diet at the same time and getting active. Then I'll bring them back and I'll see, how are you doing? At any time that I am not getting, then I would advance it up to, here is where I might go, I do lots of different things. Here I might put, depending on where the blood sugars are the most problematic, I'll add another 500. I never go to TID. They can't remember that middle dose. So if more of the problem is in the morning, I might put another 500 in the morning. More of the problem is in the evening, going into the fasting, then I might put it there. So where I increase it next depends. So it just is going to depend on the response. Here's an important point. If at any point, let's say I go up to 1,500 and they go, I got diarrhea, I can't stand it, I always have them back down. So I go back to the dose that worked because any metformin is better than none. Okay? And then I might eke it up slowly. Then I might go up by 250 the next time instead of 500. Or I'll give them a longer period of time. The only time you need to throw in the rag is when they develop diarrhea that they can't stand, because there's nothing you can do, nothing. They can't take a lower dose, they can't wait until the gut responds, it just won't. So intractable diarrhea that will not, is too much for them, and they can't tolerate, move on to another drug. Okay, questions here? Start low, go slow, move it up, always pushing diet, and you can get a good response, especially early on. Okay, let's take a break. We'll come back at 20 after, and we'll get as far as we can, and we'll do that tomorrow as well.